So, welcome to the show. Welcome, Dr. Chung. Thanks for joining me.
Thanks for having me on. Excited to talk to you.
Yeah, likewise. So, let me get this straight. So, you want to talk about the brain as well as upper cervical work that you're doing and how those two relate?
Yeah, I mean, those are my two major areas of interest, being an upper cervical chiropractor for the past 10 years and figuring out how to integrate some of the neurology from the functional neurology world with what we're doing with upper cervical. I found it to be a really good match. So I think that's stuff that has benefited a lot of my patients. I think could benefit a lot more patients for sure.
Mm-hmm. So for those who aren't familiar, what's the impact that the neck has on the brain? You know.
So the neck is basically like a bridge between the body and the skull, right? And the neck is such a neurologically dense and sensitive area that all the neurological afferentation that happens, especially from those upper cervical nerve roots, C1, C2, C3, they play such a big role in helping the brain figure out where the body is in space. And because of that, injuries that happen to that area can really cause a lot of unusual neurological symptoms that people don't necessarily think about when it comes to neck injuries. Because when people think about injuries to the neck, they're generally going to think about things like neck pain. They're going to think of things like radiculopathy going into the arms, and they might think of things like cervicogenic headaches. But what a lot of the stuff that we're seeing in my practice and many other upper cervical practices is that injuries to the neck can be associated with neurological issues like migraines, with things like trigeminal neuralgia, with TMJ issues. And we've even seen a lot of success in helping to treat a lot of subtypes of concussion patients too, just because when you get a head injury like a concussion, it's really hard to get a head injury without also injuring the neck. Right. So seeing the two kind of work together and how they relate to each other has been a big focus of a lot of what I do clinically and what I like to read and write about.
Mm-hmm. That's great. That's great. So, like you said, it's hard to have a concussion without having a whiplash injury. So how do you pair your treatments then, where you really want to address kind of both aspects of that?
So just from my bias of my training, being an upper cervical chiropractor, I always start addressing the neck first. So that's just my bias. I don't know if there's a right way or wrong way to go about doing it, but being an upper cervical chiropractor, the way that we take care of people is such an elegant and almost really too simple way of taking care of people, where if I could take care of a lot of the patient's complaint by something simple like an upper cervical adjustment and see what it addresses and how much better the patient gets, then I start there. And then once I see what's kind of remaining, then I take the brain-based approach where I see, you know, what's going on with the patient's cerebellum. Is there stuff that I could do for the patient cognitively? Is there stuff that I could do to address some of the autonomic symptoms? And because that's a little bit more time intensive and probably is going to take a lot more work in rehab, I usually start from the neck first, see what we could get accomplished by addressing the neck from an upper cervical standpoint, and I'll work downwards or upwards through the brain from that area. That's my methodology, at least.
Great. And then can you talk about a little bit of the specifics as far as the upper cervical technique that you like to employ and what someone can expect from that type of intervention?
For sure. So the technique that I use in our office is called NUCCA. It stands for National Upper Cervical Chiropractic Association. So NUCCA is the technique of that chiropractic organization. So NUCCA has its foundations in what's called orthogonal chiropractic. So orthogonal chiropractic, we basically have a biomechanical model of the spine that seeks to have the head and the cervical spine be at 90-degree angles with the atlas vertebrae. And we found that when we could establish that type of relationship, that patients seem to do pretty well. So what we tend to do is we take a 3-series x-ray on a patient, so we could get some biomechanical information from the x-ray. And then we use a really low force style of adjustment where there's no, most people associate chiropractic with high velocity, low amplitude manipulation, where you get the popping and cracking sounds from it. Ours isn't going to generate that. It's really subtle. A lot of people don't really think we're doing anything to them when we do this style of adjustment, but we could see some pretty remarkable changes in a patient's standing posture. We could see a lot of changes in their balance as far as dynamic posturography goes. And we'll see some changes in their autonomic measurements like heart rate variability, which kind of gives us an idea of how well the person's body is reacting towards that style of adjustment. And if all those things are checking all the boxes that we're wanting to hit, then our goal from an upper cervical standpoint is really to adjust the person as little as possible. It's almost like it's a merit badge for an upper cervical chiropractor to talk about how little a patient is getting adjusted, which in my view works well with the neuro model because we're just trying to do the bare minimum from an adjustment standpoint. And that way, when a patient comes in for follow-ups, then we can start working on them from a neurological rehabilitation type standpoint.
Right. Okay. And you had mentioned that it's a pretty low force light adjustment technique. Do you find that patients tend to respond, maybe there's a less risk of maybe decompensating a patient who may have a vestibular imbalance and they're compensating with the neck, and then you do these low force techniques? Do you find that patients tend to respond better with less adverse responses in those types of situations?
I do think there's something to that, especially since patients that tend to be more neurologically and metabolically fragile, they probably don't want to overstimulate them too much. So I think taking that type of low force approach makes it a little bit more well suited for those types of patients. I don't have any data to support that, but the people that come into our office, they tend to be on the more fragile on the fragile scale of things. So I think taking a less is more approach and just having at first do no harm be kind of our guiding philosophy as far as helping and treating patients is the way that we go when it comes to using a technique like NUCCA or some of the other orthogonal techniques in upper cervical.
Absolutely. And before we started recording, you had mentioned about CSF flow and how you can impact that with the upper cervical adjustments. And that's something I've been really interested. I mean, we had mentioned Chiari before. Can you talk on that and the benefits that upper cervical has on those types of conditions?
Sure. So this is a really cool thing that's probably happened in the past 10 to 15 years by an upper cervical doctor named Scott Rosa. So Scott Rosa is an Atlas orthogonal chiropractor based out of New York. And he's been doing some really interesting work and measuring how a patient's cerebrospinal fluid changes before and after getting an upper cervical adjustment. So he's using upright MRIs and he's doing fluid flow studies on these patients that he's taking care of from an upper cervical standpoint. And one of the really interesting things about that is that he published a paper where they showed some pretty remarkable changes in CSF flow in MS patients, and he corresponded some of these MS patients' improvements to these aberrancies in cerebrospinal fluid flow. And the idea was because of the impact that the Atlas can have on things like the internal jugular vein, if you have a backup in the internal jugular vein and you're affecting the brain's ability to drain itself, you're also affecting some of those cerebrospinal fluid dynamics. And when you're affecting those cerebrospinal fluid dynamics, then that leaves a person a little possibly more open towards having something like pressure changes that can cause downward movement in the brain, leading to Chiari type presentations. It could also have turbulent fluid flow that's disrupting areas of the brainstem. So there's been a pretty cool viral video going around lately that shows how CSF movement in the brain is corresponded with the heart pumping.
Okay.
And when you see this really high resolution image, you can see that even just in a Chiari patient, that how much turbulent CSF can really move those areas of the brainstem, which gives us a good mechanism for why Chiari patients can struggle a lot when they've had some type of head trauma. Mm-hmm. So just by changing the dynamics of the atlas vertebrae and changing the way that those vascular structures are draining, and you could have a direct impact on that CSF flow, which we know now can affect, how the brain cleans itself during sleep, which we now know can develop into headache type symptoms from things like hypotensive type headaches. So I think there's a whole world there that we're really trying to explore in the upper cervical world that could have a pretty cool impact on how we see some of these conditions.
Yeah. And I know Dr. Rosa, he, like you were talking, he uses the MRI kind of before and after, right? Mm-hmm. And he uses the atlas orthogonal technique. From your experience and from the research that you've read, how important is that, like the very fine specificity that he or you may be using?
I think it does make a big difference just from looking at how I take care of patients anecdotally in our office. Mm-hmm. We'll have times where we'll do an adjustment on a patient and they're just not responding in the way that we would expect them to in the first 2 weeks of taking care of them. And when we go and look at the x-rays and just make a modification to our vector or line of drive, even if it's only maybe, 2 to 5 degrees of change in the way that we're actually lining up on a patient, it has made a difference in both how the patient progresses symptom-wise and, even more importantly, from our clinical standpoint, how well they hold their adjustment. Because it's a cool thing when we adjust the person and the patient's symptoms get better, but if the patient's symptoms keep coming back week after week after an adjustment, then we're really not doing a great job for that person. So if we could just change the vector a little bit and all of a sudden that person is able to go from holding their adjustment 1 week at a time towards going a month, 2 months, 3 months at a time between needing an adjustment, then that's a big impact for that patient. It saves them money, it saves them time, and it just gives them more confidence in that it's their body that's healing as opposed to relying on the practitioner to do the healing.
Absolutely, yeah. And we don't want any of our patients to have to be reliant on us forever. So yeah, that's great.
Absolutely.
So you seem really passionate about what you do, and I forgot to ask in the beginning. So what actually got you into chiropractic, upper cervical chiropractic, and then the brain rehab?
So I started off going to college with the intention of going into medical school because, when you're in high school and you're growing up in an Asian household, you only really know, all right, you're supposed to go become a doctor. So I had every intention of becoming a medical doctor. And one of my really good friends who have become one of my best friends and still one of my greatest influences now, named Matt Westheimer, his dad is a chiropractor. He knew from a really young age that he wanted to be a chiropractor. So he wanted my help to help him start a chiropractic club at the University of Central Florida. So I helped him out with that. And one of the cool things that kind of evolved is the healing philosophy of chiropractic, where at its core, it's just about what do we have to do so that the body can sustain itself and heal itself and take care of itself better, as opposed to having to rely on drugs or interventions in order to keep the body healthy. And that really resonated with me because that's kind of always how I live my life. So I started getting chiropractic care from him, and things like tension headaches went away, nagging sports injuries went away. And I was like, you know what? I could do this. I think this would be a cool thing to do. So I ended up switching gears and going into chiropractic school. And during chiropractic school, right around my last year of chiropractic school, I was really curious about upper cervical chiropractic because some of my friends and some of my mentors were just seeing these really interesting cases of people with things like fibromyalgia and Parkinson's disease and things that you don't necessarily associate with chiropractic showing improvement just from getting their upper cervical spine taken care of. So I ended up learning NUCCA and taking my first job at the NUCCA office. And I kind of stumbled into neurology when I was taking care of a lot of patients, and I started to get a reputation for doing really good work with post-concussion syndrome. And while I was getting a lot of people better, I realized I didn't really know that much about concussions. So I kind of went down this rabbit hole of reading concussion literature, and then that's where I just started going like crazy looking at some of the work that Dr. Carrick was doing with it. And I started taking a lot of the courses through the Carrick Institute and taking the classes with Dr. Traster teaching, and it's really changed my approach towards understanding that things can go beyond the upper cervical spine, and we could actually take it into a higher plane by helping the brain recognize itself again. So it's really been a great joy and a benefit, and it's something that sparked a strong intellectual curiosity in me, and it's something that I think adds a tremendous amount of value for patients that I've seen that have plateaued, or patients that I'm seeing now who will get to experience that even beforehand.
Mm-hmm. That's great. That's great. So you've seen some pretty substantial improvements from just taking the chiropractic aspect, the upper cervical aspect, and then pairing that with the brain approaches as well. That's awesome.
Yeah, absolutely.
And where do you practice again?
So my practice is in a town called Wellington, Florida. It's a town just outside of West Palm Beach. So West Palm Beach is about an hour north of Miami. So if you're, I'm somewhere outside of the state of Florida, we're kind of an hour north of Miami. So yeah, I'm in a town called Wellington, which is a pretty nice horse community, which does see a lot of post-concussion issues on people falling off horses.
Yeah, I would imagine. And then you had mentioned earlier that you have a blog, right?
Yeah, so I do a lot of writing about some of these topics involving, concussion, whiplash, and its impact on the brain at a blog called protecttheneck.com. Okay. So a lot of my writings are on there. You could also see what I'm writing about on social media. On Twitter, I'm at Dr. Jonathan Chung, Dr. Jonathan Chung. And my practice is Keystone Chiropractic and Neuroplasticity. So if you ever look that up, then you can find out more about our practice. And if you ever needed to, get an upper cervical approach with neurology and wanted to take a nice trip to West Palm Beach area, then we'll be there for you too.
Not a bad place to go visit, right?
Yeah, not too bad a place to spend for an intensive.
Yeah. So what are some of the topics that you cover in your blog? Like what's your favorite topic that you've covered in your blog?
One of our favorite topics that we covered in our blog was about Chiari malformation. So we talked about some research that was done by a gentleman named Michael Freeman that showed that a large proportion of patients in auto accidents develop cerebellar tonsillar herniation, but a lot of it goes undiagnosed because the type of imaging matters. So the study showed that if you took a group of auto accident patients and you threw them into a kind of your classic recumbent MRI, that you'll have about a 7 to 9% incidence of cerebellar tonsillar herniation, which matches what we would generally see in the normal population. But if you took that same group and you put them into an upright MRI, just the way that gravity impacts the biomechanics, you actually see that many of these patients do have tonsillar herniation. Up towards of 23% of patients have a tonsillar herniation after an auto accident, whereas the control group that didn't have the auto accident has a cerebellar tonsillar herniation roughly around the same rate as the general population. So we broke down that study a little bit, which kind of opens our eyes to maybe whiplash injuries are pretty more significant for the brain than we had originally thought. So that's probably one of my favorite topics that I wrote about. I write about pain neuroscience education a good bit over there. and we talk about post-concussion syndrome. We'll get him out over there too.
Okay. So I was hoping that we could touch on the topic of cervicogenic dizziness.
Sure.
And how might somebody know if maybe they've got that going on, or and then how would you approach that with the patient?
So kind of your classic cervicogenic dizziness is probably going to come if you have something like neck pain that goes along with it as well. Mm-hmm. But what we're seeing in our office is that a lot of patients with cervicogenic dizziness don't necessarily have the neck pain concomitant at the same time. They might have a history of it, but a lot of times they don't have that symptom presentation together. So one of the things that we notice a lot is that when patients have a sense of dizziness, but it's not really vertigo, meaning they don't feel like the room is spinning, they don't feel like they're spinning, they just have a sense of feeling off balance, they don't feel stable when they're moving, they sense motion, but it's not necessarily that rotational dizziness, and they don't have a history of things like neuropathy or any other causes that might lead to a vestibular imbalance, then we start to think, okay, they might have cervical afferentation issues that are causing this sense of imbalance. So we'll look at their health history, we'll see if they've had a history of whiplash or minor head injury, and then we'll do some testing with them. So we'll have them stand on a foam pad and we'll stress their neck by having them turn and see if turning their neck while standing on the foam pad causes them to lose their balance. We'll do tests like a smooth pursuit neck torsion test, where we'll look at their eye movements when their head's in a neutral position, and then we'll turn their trunk and we'll see what happens when we activate some of those cervical afferents and see if their eye movements get distorted from that. Mm-hmm. And if any of those tests show up positive, then dollars to donuts, we have a cervicogenic dizziness type complaint that's probably matching up with their symptoms. And fortunately, we've had really good success being able to manage that just by getting a really good adjustment on them. So it's actually one of the things that I will pre and post test on every patient that I suspect has it, is if they stumbled off the foam pad when they had their head turned, then immediately after the adjustment, we'll throw them back on the foam pad with the same head position and see what their stability is with that. And that has been a really good predictor to let us know that the patient's going to get better or not.
That's great. And typically, what do you see as far as a time frame with healing from a cervicogenic dizziness?
With cervicogenic dizziness, mm-hmm. If they definitely do have a cervicogenic dizziness and they don't have any other vestibular issues going up with that, we expect them to get better really quickly. So within 2 to 3 weeks, many patients will feel 60 to 75% better and a lot more stable. So it's one of those things where it doesn't take a whole lot of adjustments or a whole lot of time mm-hmm. To see improvements. And many patients, we expect them to feel a good bit better within a week of seeing them. So it's something that we do expect to see get better relatively quickly if we were on the nose with the right diagnosis.
Right. That's great. That's great. Well, Dr. Chung, I think we're about out of time. Did you have any closing remarks for us before we get going?
No, I mean, I enjoyed having this discussion, and I love that podcasts are coming out that are talking about neurology in interesting ways. So absolutely. I love the work that you're doing and hope that more people get to learn about this crazy cool thing in neurology that we all have the privilege of doing every single day.
Yeah. Hope so too. That's our goal, right? And again, if anyone wanted to reach out to you in your clinic and your blog, how would they do that?
So the best way you can find me on social media is at Dr. Jonathan Chung on Twitter, or you can look up my practice website. It's Keystone Chiropractic and Neuroplasticity. And if you just do a Google search there, then that'll be a link to our phone number, our email address, and all of our social media handles.
Awesome. Well, thank you very much again. It was a pleasure getting to talk to you. This has been your host from the Neuro Wellness Podcast, Dr. Coppus. Be well.